Hi, this is Andrea Kane, and I'm here with HIT 340. We are now into week 8. We are on comparative records, chapter 9, intellectually disabled. If you are looking at your course guide, we are on 8.3, which means unit objectives 8.3.1 through 9.3.4. And again, you can find that in your syllabus. If we move forward, our learning objectives today through the PowerPoint are to talk about the major differences in settings provided to an individual living in an ICF or an IID as compared to other settings, and then the various methods of record keeping and separation of information for individuals that are in those settings. So let's go into this. We're also going to explain the need for utilizing various coding systems and classifying data. For those with intellectual disabilities, we will discuss the process involved in risk management, tracking and trending of accident or incident reports, and technical aspects of HIM management when you're talking about an ICF or an IID. So here we go. An ICF, IID, is an intermediate care facility for individuals with intellectual disabilities. There are ICFs that do not care for individuals with intellectual disabilities, but what we're going to talk about today are the ICFs that do. They are committed to helping individuals reach their fullest potential. They have to have training objectives in each individual's plan, and the placement of each individual should be in the least restrictive setting based on their disabilities. So for instance, they could be in a group home, which has a little bit more independence than an ICF, which at times can seem very similar in some ways to a skilled nursing facility or a nursing home, especially when you're talking about state-owned ICFs, which I don't believe Iowa has, but I have worked in other states that do. So types of settings, they can be operated by various groups, government, religious, private, and so on. Some facilities focus on specific populations by age or diagnosis, and generally the goal is to acquire skills to live and work in the least restrictive setting. And this is where I talked about group homes, supervised living, supported living, that sort of thing. Really trying to help these individuals be able to live the most independent life that they can with acknowledging their disabilities, but also teaching them life skills and some of the the things that they need to be able to take care of themselves, those acquired skills. So interchangeable terms: intellectual disability, intellectual developmental disability. Those are interchangeable terms. Unfortunately, the term mental retardation was coined a long time ago and has stuck around for a very long time to describe those who have intellectual disabilities. And you will still hear, unfortunately, people who use that terminology. But we want to talk about intellectual disabilities or intellectual developmental disabilities. These are people in need of active treatment. They receive services that and are traditionally called clients, sometimes students or residents, depending on the setting. Often they prefer to be called an individual or a person. And I think that's really important to remember. Even though they have these types of disabilities, they are still an individual or person worthy of respect and certainly worthy of compassion and assistance. So, what are the types of caregivers in these settings? Well, usually it's an interdisciplinary team, and the disciplines depend on what the needs of the individuals are. The individual and their family members are part of the team. They use assessments to formulate a plan, and those assessments are based on each individual, what their disabilities are, what their needs are, what their skills already are. It is very person-centered in terms of planning and thinking. They want to have personal choice. They want to use sets of value, skills, tools in this person-centered planning. A qualified developmental disability professional, or QDDP, is the one who coordinates and monitors the plan and makes sure that the team is made up of the right disciplines to address what the individual needs. In an ICF, there are healthcare staff, habilitative staff, and administrative staff. So it would be, you would have your nurses, you would have your nurses' aides, you would have probably some rehab staff as well as administrative staff. Lots of people to help care for the patients and work with them. So there are conditions of participation for ICFs for IID. They have to be met to receive federal funding, such as Medicaid, because most of these individuals are on Medicaid. So when you're thinking about the intellectually disabled and ICFs or group homes in those settings, really be thinking about the fact that the funding is Medicaid, and be thinking about what Medicaid requires. Medicaid is both a federal and state joint program. So you're going to have some federal government requirements. You're going to have some state requirements. You're going to have documentation requirements, accreditation requirements. So again, you have regular surveys by the state and or joint commission. And this is another one, Council on Quality and Leadership. And they look at personal outcome measures. So make sure that these two slides you're very familiar with. All right, documentation. Definitely they have administrative forms as they would in any other healthcare setting. And then there's definitely healthcare related forms about their physical health and mental health as well. And then habilitation and training. This is where they're getting into making sure that they can care for themselves, making them more self-aware and aware of others and how to get along, how to do tasks that may lead up to employment. They have 24-hour training schedules documented, and statistics from the training documentation are used by the interdisciplinary team to assess the accomplishment of goals. Because of course, if you've got a plan, you want to assess it and you want to see how close they are to getting those goals accomplished, same as any other setting. There are admission decisions and preliminary evaluation. Of course, you know that admission assessment, and definitely they have to be cleared by a physician. Transfer or discharge, there's a final summary and post-discharge plan of care that would go with the individual. And then the individual's program plan that's prepared by the interdisciplinary team must be done within 30 days of admission and updated at least annually. Again, this is really important for you to know. Hint, hint, hint. All right, so reimbursement and funding. Medicaid provides most funding, as we talked about. It is per diem payments. In some states, the level of care affects the amount of per diem payments, which makes sense if you think about it. If it's an ICF setting, that's a lot more intensity of use of resources, and versus a group home, which is probably not going to use anywhere near the same amount of resources. So there's some case mix adjusted based on standardized assessment. And then funding models are based on managed care. They have to consider the need for training and other types of supports in addition to healthcare as well. There has to be a chronological flow of data. I mean, if you think about it, the patient's or the client or the individual is admitted to the setting, and everything that happens after that has to be maintained because you want to be able to see the progress. So there's a flow of documentation. Sometimes it's decentralized to centralized storage. There are imaging programs for active versus inactive records and retention, those types of things. So again, go back to your book and go through these sections there. Coding is ICD-10-CM and DSM-5. And then intellectual disability, the AAIDD Intellectual Disability Definition Classification System supports 11th edition. Would encourage you to look up the AAIDD and just read about it so that you're familiar with it. Hopefully by now you know what ICD-10-CM is and DSM-5. But if not, make sure you look those up. All right, so electronic information systems, mostly they're business functions. But they do sometimes integrate departmental systems and have hybrid record systems because so many of these keep their information still on paper. And so maybe it's scanned later or maybe it's stored. Databases for important data because they have to be able to submit data and trend data and that sort of thing. And then imaging systems require standardized forms and reports. The data collected varies from state to state and facility to facility. There are certain standard items that are required by the conditions of participation. And hopefully as you do your assignment this week on risk state profiles, you'll see the data that's collected and how that's utilized and that sort of thing. There has to be an annual assessment of the individual, and then standardized assessment data. They use these items to make sure that they're doing it consistently and can compare apples to apples, patients to patients, individuals to individuals across the country. So some typical forms and data that are maintained: there's identification data, authorizations and consents, inventory of belongings. There are also updates, court team summary sheets, 24-hour active treatment schedules, physician data, nursing data. There's quality improvement, looking at facility-wide endeavors, for instance, infection control in an ICF setting. Are there any accidents or incidents, medication errors, seizure frequency? Looking at just what's happening with the individuals. Are there any safety issues? Are there any emotional meltdowns? Are there issues where there's some kind of conflict going on between residents? Those types of things. So then utilization management: are they in the most appropriate setting for the individual? Because again, if they can be in a group home, that's where they should be, not in an ICF, which is a lot more more towards the skilled end of things. And looking at the efficient use of resources, as well as an example of that is a formulary. Risk management: every death has to be automatically reviewed. Every incident and accident report has to be reviewed again, and asking the question, could the situation have been prevented? And that's where you get back into my brain just stopped for a minute. Oh, root cause analysis, RCA, that's what I was reaching for. So you do an RCA on the situation. Could it have been prevented? Where were the holes? How do you make sure it doesn't happen again in the future? And then method of correcting errors. As we all know, the correct way to correct an error in a medical record, if it's paper, is a single line through the incorrect entry to write the correct information and the date, time, and authentication by the person who is making the correction. And then, so then you've got the editing documentation and records, the addendum, and adding the addendum, making sure it's identifying who did that, why did they do that, and then use of technology. Legal issues: there's absolutely confidentiality. They have to have a signed confidentiality statement. They are under HIPAA. Protection of records: they're the property of the facility. They have to be protected from loss, damage, tampering, and unauthorized use, because if they're paper, think about this, they have to be you have to make sure they're securely locked away, that there's a way to manage who has access to them, when do they have access to them, how do they have access to them, how do you take care of them to prevent damage in case of a flooding or in case of fire, or those types of things. And then written policies, procedures are absolutely necessary, as well as having a record retention policy. So what is the role of the health information manager? They are a full-time employee. They have management duties, responsibilities, development of policies and procedures. They run the HIS area, whatever that means, whether that includes from registration, the revenue cycle from registration to billing, or whether that just includes the medical record side of things. They retrieve health information, they compile, analyze it, they do the coding. They can be a consultant for quality management. Trends are to move away from large facilities to community residential settings. If you do any kind of research on this, you'll notice that way back, it used to be that these were state-run facilities, very large nursing home-like state-run facilities. They have now really moved a lot more to group homes or community residential settings that give the individuals a lot more freedom and a lot more responsibility and ability to live as close to a normal life as possible, which is awesome. And then there have been funding changes, increased expenditures through waivers, and then there's been effects of litigation. And I'm not going to go into this because I believe that your book covers it in fairly good detail. So in summary, the ICF IID setting serves individuals with intellectual disabilities. They have healthcare, habilitative, which is that training piece, and administrative staff to work with or on behalf of the individuals to help them achieve their goals. They have to meet federal standards remember the conditions of participation. They may choose to meet voluntary accreditation standards. If they don't, the state will come in and review them. They provide community-based services, and that continues to be the trend. Don't forget about them being mostly Medicaid, because again, that will, when you keep in mind that payment source, that'll help you as you think about documentation, as you think about billing and reimbursement and accreditation, and what kind of government regulations they're under. So this gives you conditions of participation that you can go out and take a look at if you want more information. And that is it. So I hope you're doing well. I hope you're having a great week. I look forward to talking to you next week when we will move on to Chapter 10. And Chapter 10 is on long-term care, so we will get into those SNFs. All right, take care. Talk to you again soon. Bye.